The presentation, like I said, Helen is the one that helped me prepared it. So you will see that I didn't change anything at all. I didn't want to alter or dilute any information that I got from her. So it's basically going to be investigation and debrief.
Dr. Mitei.
Yes. Yes.
Please put it on projection.
Oh, okay, Sawa.
Please.
Let me do that. Is that okay?
It's not yet. You have not clicked.
Oh, it says I've paused it.
Can you, if you go to slideshow, will that help you? See along the top where it says slideshow.
Enable editing first. Enable editing first, then you click.
Oh, okay.
Yeah.
Let me see.
Enable editing at the top.
Here.
Yeah.
Okay. Click
it
read
asks
only.
For
Read
okay.
only.
Yes. And then we go here.
Yes.
So are we okay now?
Yes, we are.
Okay.
Okay.
Okay. So that's the topic of discussion today, and our learning objectives are going to be to understand the nature of adverse clinical incidences, and of course to be able to define what are the clinical incidences, to appreciate the key steps to take in investigating and managing an incident, to understand the role of debriefing following adverse incidences. So then, what is a clinical incident? A clinical incident is any unplanned event which causes or has a potential to cause harm to a patient. An adverse event, however, is an incident that results in harm to the patient. So an adverse incident is defined as any event or circumstance that led or could have led to serious unintended or unexpected harm, loss, or damage to the patients. So we have several types of clinical incidences, and these are just but a few, but the list could go on and on. It includes fresh stillbirth, maternal death, uterine rupture, fistulas, serious drug and transfusion errors. That includes omission of doses that were already prescribed, maternal morbidity, birth asphyxias of the newborn, neonatal deaths, acquired infections, that is nosocomial, and others according to, like I said, the list goes on and on. So what incidences should be why should incidences be investigated? Take a minute and look at this list. Let me say 30 seconds to just have a look at this list before I move to the next slide. I believe that's 15 seconds, so I'm going to move on. Like you see, all the reasons that I gave are reasons why we should investigate incidences, except two. That is, we don't do investigation of incidences to be able to find who to blame or to discipline the staff involved. This is because most of the time the incidences happen as a result of faults in multiple issues and issues within the health system, and you cannot really place that on one person. It can't be one person's fault. And if you blame individuals, then you find yourself in circumstances where individuals will not really be open to discuss circumstances that surrounded an incident. So people will not be open to discuss what factors led to whatever incident. So the principles of investigation, first of all, as a facility, we are supposed to have a policy, an investigation policy that should then be followed and followed when investigating a case and should be adhered to. That's the first thing. So the reasons why we do investigation is, first of all, to be able to find the truth, adapt a no blame culture. Like I said, you cannot blame one person for something that could have happened. It could be multiple issues. The aim is not to humiliate anyone, but to respect everyone that was involved in treating or managing the patient with respect. It should be able to encourage openness and honesty by all involved, and it should be thorough. That is, it should go into depth. And sometimes going into depth and trying to find out facts may take more than an hour. So, and it also takes a lot of energy, but yeah, you should be thorough. Be confidential, that is to adapt a need to know policy during an investigation. So therefore, if you're doing an investigation, in this case, you should only involve the people that need to know. The other team in the or the other people in the department should only be let to know the learning points. The learning points should only be revealed to them, but not the details of who said what and who did what. So it should actually be very confidential. The reason as to this is sometimes when incidences happens, there is a tendency of people gossiping and trying to talk about incidences in a way that would actually not be very relevant. So it should be confidential, and only the relevant learning points should be revealed to the rest of the department. It should also be very diplomatic. Sometimes you'll be dealing with people who are very senior to you. So you should not be unduly differential to the seniors. If the policy, like I said, you should have an investigation policy in the facility. If the policy says that everyone involved in the incident should write a statement, then they should be able to write it as well as seniors, sign it and date it. So everyone involved, if the investigation policy says so, should be able to write and sign and date their statements. I'm not able to move to the next slide. Okay, yeah. So how to investigate an incident? Like I said, it should follow the investigation policy that has been set by the facility. All the relevant information concerning the incident should be collected. These are not personal opinions, but facts, the factual things that actually happen. It shouldn't be personal opinions. We should obtain witness statements from all involved. This might include even the patients and the staff, or I mean the patients and the relative. Interview of the relevant staff, that is the staff that were involved in managing the case in hand, that is the incident in hand. It should gather additional data, for example, staff duty rotas, the number of patients that you had in the ward. This helps in knowing. This also helps in knowing if the number of patients were, let's say, equivalent to the staff that were available, so that you know if it was thinly spread or the patients were more, then probably some kindly everyone who's not unmuted their mic, please unmute your mic so that I'm able to present without interruptions. So like the additional data will include that. Even the staff mix, do you have junior staff only working, or it's a mix of junior staff and senior staff? So the principles of this investigation should be adhered to, and a timeline should be set. And it should be able to look beyond individuals and look at systems. Like I said before, it could be the reasons why we have we need to investigate this. It's sometimes the problems is not really on one person. It could be a system related problem. So while doing this, you expect to find multiple reasons for an incident, and using a fishtail model would help you to be able to pick the problems at different points, that is multiple points, including equipment or staff. So I'm going to show you the fishtail model. It looks like this. So you have equipment and supplies. For example, if the equipment was not non-functional, let's say the anesthetic machine, maybe the oxygen sensor was not working, or it stopped working, or you actually had supplies, but they were expired, or lack of supplies altogether. Then we have environmental, that is the location, the physical layout and visibility. Let's say, for example, if it's a patient that requires a one-to-one care or a patient that needs to be monitored very closely, are they placed in a place where you are able to visualize and maybe notice any changes in anything? Is the building safe as well? Then we look at the rules, the policies, and the procedures. These are this includes things like standards. Are these standards up to date? Are they placed where everyone can see? And are they available? And if they're available on hard copy, then it's also advised that we provide a soft copy for easy references of the staff. Then we have staff and people. Do they have adequate knowledge? Was the rota well balanced? The form of communication that we have, is it verbal? Is it written? And then in terms of supervision, do you have juniors working alone, or you have seniors who are able to then at least provide supervision or mentor or show how to do certain things that the juniors may not be able to work? If you look at all these 4 factors then and dissect them properly, you'd be able to come up with a problem statement. This leads me to the next slide. Once you have a problem, you
Looks like we have lost Dr. Mitei. Dr. Mitei?
I think I disappeared for a minute.
Yeah.
Oh, sorry. So you disabled sharing the screen, so I'm not able to share again. I don't think. Mirite? Hello? Hello, Mirite?
Hello, Dr. Mitei.
Yes, you've disabled my sharing, so I don't know how far I went.
Did I disable or you went off?
It says the host disabled participant screen sharing.
Mitei, now you are now the host, Mitei.
Okay, how far did I leave you? How far did I leave you?
Just immediately after the fishtail slide.
Yeah.
Okay, okay. Okay. So after the fishtail model, we have the root cause analysis. So I was saying that after you identify the factors that could have led to the incidents, you then have the ones that you'll actually call the root causes. And those are the ones that you need to analyze, which means you define the problem, collect all the facts, and then ask the why.
The slides again yet. The screen. Can you share the screen again?
Sawa. Give me a minute.
You're doing really well. This is very hard to do when you're not used to it.
So let me start again here. Are we there?
Yes.
Are we there now? Okay.
Yeah.
You're there.
You're there.
Okay. So then should I start this slide, or at least you had something I said about this slide, because I was about to finish.
You start, please.
Okay then. So I was saying, after the fishtail model, which helps you come up with several problems that could have led to the incidences, you then classify them to be able to find the root causes, which are the ones that you will now define as a problem, collect all the facts, ask the whys, and just Identify the corrective actions according to the factors that you called the root causes and not just the symptoms. Identify solutions that will help the problem from happening again, and also that will not cause more problems. And then be able to implement the solutions that you came up with. So like I said on the previous slide, ask the whys. So you have layers of whys. So you have the effect, which is the problem or the root cause. Then you'll have to ask, why did that happen? And then ask, why did the why happen? So there was a study that was done in Uganda. I'm going to show you that to be able to demonstrate the meaning of layers of the whys. So this was a study that was done to see why nurses arrived late for work. So the first whys came up with these answers. There was delays in collecting water for washing, problem with childcare arrangements, have to farm in the fields before work, and there was lack of discipline, and some of them didn't know the time they should arrive to work. Now, when they asked the whys to the first why, they realized that there was only one standpipe for nurses to fetch water in the village, which led to long queues, hence the delays, and also the water reservoir was broken. So in the second why, I'm going to end on the third why. In the second why, they found out that they were the only ones who were able to look after the children. Then the third why, which is having to farm in the fields before work, the reasons became the wages were too low, and they also said that the payments were late, and so the additional payments were always late. So if you go to the second why, then the suggested solutions were to repair the broken taps and to build new reservoir above the nurses' village. I hope you've understood the fishtail model from this. I'm going to move on to the next slide. So the next step after you found out the root causes of the incident, you have to follow the SMART action plan. That is specific, measurable, achievable, relevant, and time-bound. Define who will be responsible for each action that you come up with. Give a timeline and identify who is going to check that these actions have actually been done, and also a written report including facts, timeline, and investigation findings, and the action plan. So some examples of the actions include, among others, creation of clinical guidelines or updating clinical guidelines if you have those, and make sure the guidelines are readily available. If you recall, I said in the beginning of the presentation that if you could make this electronically available so that it's easily accessible to anyone who has a smartphone, which I believe most of us do have. And then specific CPD sessions. This is now like having refresher courses on different conditions that might be causing incidences or deaths or morbidities. Structural changes to the environment, changes to the rota to ensure adequate skill mix on duty. That is, you have junior staff and senior staff working together so that they are able to supervise and mentor, and also the junior staff can learn. Specific training for individual staff as required. So if you identify, for example, a staff is weak, let's say in vacuum delivery, for example, you could do that as a mentorship. You attach them to someone who would be showing them how to do vacuum deliveries. And then enhanced supervision, which should be supportive. So are we therefore saying that no one should ever be disciplined if an incident occurs? No, we are not saying this. We are only saying that if you have a code of conduct in the facility and it has been identified that this person has gone outside the code of conduct, like that is having an unacceptable behavior. For examples of these are drunk on duty, absent from duty without informing or just cause, abuse of patient, discriminatory behavior, bullying of staff, or corrupt behavior, which includes stealing from the hospital or stealing from patients, then this is unacceptable behavior. In this case, then we should have a disciplinary policy where the code of conduct and should be known to all staff and patients. So when we are doing staff debrief following an adverse incident, first of all, no one wants bad things to happen when they go to work or when they are at work or when they are anticipating to go to work. So most times this, when incidences happen, staff are frequently very distressed. And debrief can be very helpful if done in a supportive manner. That is, done in a way that you're not trying to find blame, but letting someone talk about the incident and giving facts that surrounded the incident. And this is done in an aim to help individuals to come to terms with difficult emotions generated by the experience. The best time to do this varies, but it's best done fairly soon after the incidences when the emotions are still raw and memory is still fresh. Confidentiality is paramount. So it should be very confidential, and you should be, as the person who is conducting the debrief, you should be able to give that space where a person knows what they say in that room shall remain in that room and shall not be discussed anywhere else. And as a person also conducting the debrief, then you should be able to listen more than you talk. So characteristics of effective debriefing. First of all, it should not be compulsory. It should be offered, but someone should be able to say, I am not able to attend a debrief now. And it can also be offered as a one-to-one or done for a group. So some people may be more comfortable talking on a one-to-one, or some may be comfortable if they did it as a group. But ground rules should be set, and we should stick to them. Are you following? I don't want to lose you again.
We are following.
Mirete?
We are following.
Okay. So you should be able to allow the staff to choose not to attend a group debrief. So let's say, for example, it's an incident that has happened, let's say in maternity. So you have several people that were there and you'd want to conduct this as soon as the incident happened. If somebody chooses not to attend that debrief in a group, allow them to choose if they want to have one-to-one, or they want to do it later, or they do not want to do it at all. Allow them adequate time, and it should be the debrief should be led by someone who was not involved in the incident. So it shouldn't be someone who was involved in managing the patient or who was there during the event. Debrief should be led by someone who is also trained to do so. And the person conducting the debrief should be prepared to say very little, or should be prepared that people may say very little or nothing at all, or some of them may be wanting to talk a huge amount. So you should be able to allow people to do this and listen and watch their body language. If, for example, you see somebody feeling very uncomfortable, you can tell them, I see how this has affected you. Give them that space to know that they're in a comfortable place, they're able to talk or able to share their emotions. Also, as the person conducting a debrief, you should be prepared for tears or people getting angry. You should allow that to be expressed, and you should be prepared for that. As a person also conducting the debrief, you should be non-judgmental at all times. And if anyone, or if the entire group that you're doing the debrief for wants to do a follow-up with you relating to the incident, you should be able to offer to be available. So again, should patients and families be offered a debrief? It's a huge yes, but it should be done by a skilled and experienced person, and it should not be done together with now the staff debrief. The debrief of the patients and the family should be done differently, and people the relatives of the people should be allowed to talk, and we should listen to their ideas. as a person conducting the debrief, you should be able to listen quietly and respectfully to anger, frustration, or grief. Acknowledging and saying sorry for the suffering is important. It's not an admission of right. So of guilt, I mean. So if the patient, for example, is feeling so angry and frustrated, saying sorry does not mean that you're actually admitting that you did something wrong. So that you should not hold that back. Be well prepared with a full understanding of the incident and report. So you should be able to give them facts of what happened concerning the incident. Be honest and avoid ascribing individual blame to staff. So do not try and say so-and-so did this and cause the relatives to think that there is a particular staff that should be blamed for this. It should just be honest and do not pinpoint or try to blame anyone. People that want explanations and to know steps will be taken to avoid, want explanations and to know steps will be taken to avoid adverse incident happening to other people. So honest explanation can help to avoid complaints escalating. So if you explained honestly to patients, then in cases that could probably could have been misunderstood as maybe negligence or something that should be blamed on someone. If you gave an honest explanation, then complaints that could have escalated would then be averted. Then emphasize the learning and measures taken to make the improvements that have come from the incident. So you can explain or you can do all this while debriefing a patient's relatives and their families. And yes, it is very important to conduct debrief. So in summary, adverse incidences will always happen. Investigations should always follow a protocol that has been set up by a facility. So we need to come up as Kilifi County, we need to come up with an investigation policy so that we are able to follow this. Then it should always aim at learning, and we should be able to recognize the system errors, which are often key. Avoid at all costs to blame individuals, be honest. And now on the matters about debriefing. Debriefing should be done by someone not conducting the investigation. Debriefing should be confidential. Adverse incidences are upsetting for everyone, and it should aim to help staff come to terms with the emotions generated by difficult experiences. So, like I said, when I was talking about debriefing for debriefing for families, I said we shouldn't conduct debriefing for patients and staff and families together. So if it's for the patient, let it be the patient alone. And if it's for the family, that is in the case of now complications that could have arisen from the incident. Let's say, for example, fistulas, things like that. So if you're explaining to the family, it should be different. We should debrief the family differently from the patient. And also when you're doing debriefing of the staff, you should not mix them up together with the patient and the families. That's the end of my presentation. I am going to allow Onesimus to say something before Helen takes over with the questions. Thank you very much.
Thank you very much, Mitei, for that very good presentation. And I believe all of us were able to catch something from the presentation. I may not say much at this juncture, but I would say that all these incidences that have been mentioned in this presentation are incidences that are faced by health workers in their experiences, whether you are working in maternity or whether you're also working in other departments. And I think it is very, very important for us health workers or even managers who are here to have this in mind that health workers go through emotional experiences because they are human beings as they provide care to their patients, and debriefing is very, very, very important to them. But also investigation, which is also very, very important in improving the quality of care. Because again, unless you do a thorough investigation, most likely you will not be able to identify the root cause of a particular problem. And that means in the solution of the problem, you may end up tackling the symptoms rather than handling the root cause of the problem. So this session is very relevant to us here, both the investigation and also debriefing. And I'm also aware, I know of course Helen is going to speak much more on this. I'm aware that when, for example, a maternal death happens in a facility, I have experienced that the entire facility, everybody is very emotional. People get sad, others during maternal death reviews, they get emotional, they cry. Others are very angry, tempers flare up because people are very emotional. So I think it's very, very important that we learn how to do debriefing, because health workers are also affected. We also develop relationships with our patients as we care for them. So any unusual incident will, of course, affect us. I'm aware, for example, currently, although this one may be a bit off the curve, that due to the COVID-19 situation, the health workers are also going through very high emotional tension because they fear for their families, but they're also experiencing bad news at different times. And this also is very emotionally tensing for health workers. So this topic for debriefing is very, very relevant, because rarely will you have somebody caring for health workers. Health workers will care for others, but rarely will you find moments whereby there is another carer for the carers. So at this juncture, I'll open the discussion to Helen, who is an expert in this area, to talk to us. I was just trying to jog our minds so that Helen can come in. So Helen, welcome to this session.
Thank you very much. This is a difficult area. It's something that we've been doing for some years in the UK. I think there are two completely separate issues, really. One is to do with getting to the bottom of why things went wrong so that we can stop them happening again. That's the whole point of it. We don't want bad things to keep happening. And the other is that the debriefing is a much more supportive thing. So, and it's much more to do with helping people come to terms with those very difficult feelings that they experience, as you've rightly said, following a bad outcome. And, you know, I can remember leading some group debriefs, one that I led after a maternal death back home in England. And one of the people who was most distressed of all was the cleaner. And everybody had forgotten about her. You know, she was just kind of there. She obviously wasn't treating the patient, but she saw everything and she was so distressed. And it only came out in the group debrief how we need to care for all the staff, not just necessarily the clinical staff. So people who see things can be very traumatized, even if they're not involved themselves in the clinical care. So don't forget people like that. And I think what I would say about leading debrief is don't be worried about people's emotions coming out. You know, people will cry, they will shout. I mean, you can set rules for the debrief that nobody is going to be rude or say bad things about each other, but just the pain, the emotion will come out, and that's okay. It's better to let emotion out than to bottle it all up inside. So I think you have to be prepared as a skilled debriefer to kind of be a shoulder to cry on, really, whether it's a one-to-one or it's a group. And sometimes in a group, if somebody's particularly distressed, then it might be better to say, you know, let's have a bit of time together on our own later on, sort of thing. There's a question here: how can we best discipline staff who might have deliberately caused an incident, as well as not causing fear to other practicing staff in the department? Do you think staff actually do deliberately cause incidents? I'm not sure that they very often do. Is that something you find?
I don't think so.
I think people make mistakes because maybe they don't know the guidelines, or there's not guidelines, or they just make a bad choice. But I don't think they very often deliberately cause an incident. I think this is where you have to have a code of conduct for your your facility, and you know, we saw a list of some of the things that might be on it. For example, it's forbidden to come to work under the influence of alcohol. You know, somebody's done that, then when you sign your contract to take up your job, you get given the code of conduct and you sign a thing to say you'll agree to it and to adhere to it. And then if you don't, you know very well that you'll be disciplined, and everybody will know that. So that means everybody will adhere to the code of conduct. But I think making a mistake that leads to or contributes to an incident, it doesn't necessarily cause the whole incident, is a different thing than deliberately causing an incident. So I don't know that I would say staff very often deliberately cause an incident. Another question is, who do we give the task of debriefing? Does the facility hire a counsellor? Well, not necessarily. It depends on if any of your staff have got counselling skills. I spent many years doing a lot of counselling, so I was able to run debriefs myself and support people, and I very often did. But I guess if you don't have anybody with those skills, maybe a counsellor could come and do some training of a select group of staff. So perhaps they could, you know, run a short course on how to do debriefing for you. And how do we separate the debrief from the inquiry into cause of death in cases of medical negligence? So again, the debrief is a separate process. It might be the same people. I mean, even if somebody's been negligent, in hindsight, they might feel terrible about it, and they might really need a lot of support. So, but just ask yourself, was it really that person that was negligent, or was it that nobody had trained them properly, nobody had supervised them properly, nobody had made guidelines available to them for how to manage that kind of situation? So I don't know. I think it's never just one person's fault. There's usually something wrong with the system. And maybe when you look at the staffing levels on that day and the patient levels, maybe there were, you know, too many patients and not enough staff. Maybe the skill mix wasn't right. Well, who's responsible for ensuring that you have a good skill mix on the rota and that people can't just take their leaves whenever they wish? The seniors make sure, you know, we used to have a thing in my department that, you know, only 2 or 3 seniors could be away at the same time as each other, so that there was always enough seniors to supervise. And if other people were already away on their leaves, you just weren't allowed to, and that was that. So you have to go beyond negligence and think what was really going on there. And was it really just one person being negligent, or was it that the whole system contributed to it? And in that case, then I think that you will, if you look, you will find system errors that contribute that you can address. But a debrief is a sort of emotional support for staff to enable them to pick up the pieces of their emotions and carry on, because that's what you've got to do. The next patient will be there for you know, very soon, and you can't. It's very hard. I can remember as a very young doctor, I once lost a baby that was a very, I think the most awful shoulder dystocia that I ever encountered in my entire career. And I tried everything and nothing worked, and the baby died, and it was horrible. I was just devastated. And then 10 minutes later, I had to go and deliver somebody else's baby. And that was one of the most tough things to have to do, is to pick myself up off the floor, dry my eyes, and go and see another patient like nothing had happened. And that just sums up all of your reserves. And later on, it hits you and you need support. I did nothing wrong that baby died. It just was, and this is what happens in a lot of medical incidents, is that with the best will in the world, sometimes in obstetrics, bad things happen. But, you know, people need support in that event. And I think the people who supported me the most at that time were the midwives on the shift that I was with, and they were lovely. And I think without them, I would have just been, you know, in pieces. So is investigation does for the purpose of audit? I don't quite understand your question, Onesimus. Can you explain that?
I think he meant, is the investigation done for the purpose of an audit?
No, absolutely not. The investigation is done to find out why the things went wrong so that you can do something about it to stop them happening again. Well, I suppose you could say that's what audit does as well, the audit cycle does, but it's not just because we've got to do audits and tick a box. It's because we want to find out the root causes of what went wrong so that we can put solutions in place that are appropriate, that prevent it happening again. You know, we talk about something called the Swiss cheese model. So Swiss cheese has got lots of holes in it, and they're all in different places of the cheese. But we say that when a bad incident happens, all the holes line up and nothing blocks. So you just go through and then the bad thing happens. So we want to put blocks in place so that at every stage, there's a way of stopping, you know, the next bad part happening in order to sort of prevent the bad outcome at the end of it. And then Kenneth says, in most incidences, weigh in so much to staff. Does it happen in sessions or a schedule maybe? Sorry, again, I'm not quite sure what you mean by that, Kenneth. Would you like to unmute your microphone and explain your question a bit more, perhaps? Can you hear me, Kenneth?
Yeah, I was asking in instances where you have had, for example, a maternal bed or a sister bed, sometimes in the ward you find staff are very devastated. The ones who on this are very devastated to an extent of it affecting them for a period of time. So I was asking, does debrief have sessions like the counseling sessions you have so that eventually somebody is rid out of the state of the experience that they had maybe?
I'm sorry, I'm not hearing you very well. I don't know if anybody, Mitei, can you hear him better? Can you tell me what he said?
I think he was saying that when incidences happen, the staff that were involved, let's say in maternity, get so devastated. So he's then asking, does this debriefing happen in sessions or should there be a schedule? Did I understand you, Mitei?
Oh, I see, yes. Thank you.
Yes, yes.
Thank
Thank
you.
you.
Okay. Okay, so I think you can't just, it's very difficult to, you probably need to set a time to do it. But like I said, you need to offer the staff the opportunity. Do they want to do it? Do they want to do it as a group, like all the people that were involved together? Or do some of them want to do it as a group? Some of them want to do it individually. And of course, you can make arrangements accordingly. It is time consuming. It is. And, you know, it may be that just immediately after the incident isn't the right time to do it, but maybe at the end of the shift before everybody goes home is a time to start, or if there's somebody there that's got that skill, or maybe, you know, the next day or whatever. So I think it varies. I wouldn't say there was a hard and fast rule as to when to do that. No more than there is a hard and fast rule as to should you do it in a group or individually. Because people have different personalities, and some people really just can't cope with groups at all because they're very introverted, whereas other people might feel more at ease in a group than they would. They might find one-to-one a little bit more scary. So I think you have to sort of be a bit led by the people who need the debrief as to when and how you do it. But I wouldn't say that one size does not fit all. Does that answer your question?
Yes, it has.
Oh, great.
I think that's it. Helen, probably just make a summary, then close for us the session, please.
Okay, thank you. So, well, thank you everybody for listening, and thank you, Mitei, for a very good presentation. I think you did me proud. And it's not easy getting used to presenting on Zoom when you're just looking at a computer instead of face-to-face with people, but it's something we all have to do these days. So I think, yeah, bear in mind they're two separate things. The investigation and the debrief are two separate processes. And so the investigation, the whole point of it is to get to the bottom of it, to find out what went wrong and why, so that you can put solutions in place to stop it keep happening again. You know, things can go wrong once, nobody's fault, it's just one of those things. But if we understand why, we can stop it again. But if we ignore it and it keeps happening again and again, then we are culpable because we didn't do what we could have done to have stopped it. And it is nearly always systems, and there are, remember those holes in the Swiss cheese lining up? It's not just one person, it's lots of things. And so we want to put lots of blocks in to stop that bad event going through in the future. Then the debrief, as I've said, you know, one size doesn't fit all, but don't forget that the relatives and the patients deserve a debrief as well. Clearly not the same one as the staff, but I think what we find in the UK, you know, where we have quite a bit of litigation, but litigation is much less when patients have had a clear explanation and they've been listened to. And very often they'll go to court because they say, nobody would tell me anything. And if you explain it to them properly, you're likely to deflect litigation rather than to encourage it. So I think it's you know, it's things have happened to them. They've got a right to understand what happened. But before you sort of weigh in and tell them, you've got to listen to them first. And I find, you know, one of the most useful things you can do is to just reflect back people's emotions. And when they're having a good old shout, you can say, I can understand that this has made you very distressed and very angry. And then they'll feel that their emotions are being acknowledged, and that helps them. They calm down much quicker then if you acknowledge their feelings rather than try and say, don't tell them they shouldn't feel like that, even if that's what you think, because it just makes them worse. So those are my top tips, okay?
Okay, thank you so much. Mitei, close.
Thank you. Thank you very much for that presentation. I want to take this opportunity to thank you, Dr. Mitei, for your suggestion that has actually come to pass. I think we need to do this as much as possible, not only for debrief, but also for other topics that we can share widely. This is a big audience. I think we are cutting across most of the areas in the county. So maybe this is the way to go in terms of passing information. And I believe the presentation was very well crafted. Thank you, Helen, again, and Dr. Mitei, Mr. Maina, my mentor, for everything. So at this juncture, then I want to close this meeting officially and say that next we'll plan for more and more of these interactions. You're all welcome. You can leave at your own pleasure.
Bye-bye. Thank you.
Thank you very much.
Bye.
Yes, thank you.
I just put my email in the chat in case anybody wants to ask any more questions or needs any more help about this.
Thank you, Helen.
Thank you so
Dr.
much.
Dr. Mitei, we are requesting for the, Dr. Mitei, please.
Yes, yes.
Just requesting for the presentation, if possible. You share it.
No problem. We did a record of this with while we were presenting, so I'll be able to share it with you, or Mitei will share it with you on various groups of WhatsApp. Is that okay?
Thank you, and goodbye.
Thank you, everyone. Thank you.
Bye. Bye.
Bye.
Thank you.
Bye. Well done. You did great.
Thank you. Thank you.
Keep in touch. Let me know how it works, whether you get a chance to take this forward and actually do it in practice. It would be great to know how it goes.
Sure.
I'll do that. I'll do that. Thank you.
Thank you. Okay.